Hi, I'm Susan Duffy. I'm a geriatric psychiatrist at the University of Iowa, and I'm going to be talking to you today about depression and cognitive decline. So I do not have any financial disclosures. So I'm going to just talk about some of the things I hope to cover during this talk, and I'm going to kind of review some things from the beginning to kind of have everybody start off from the same place. So I'm going to review the criteria for dementia and then kind of emphasize how that's changed with the new diagnoses of major and minor neurocognitive disorder. We're going to discuss areas of cognition that can be affected by dementia. We're going to review some of the symptoms of major depressive disorder and use that as kind of a jumping off point to identify how these symptoms can differ in late life depression. We're going to discuss some of the cognitive changes associated with late life depression and their associated risks. We're going to kind of figure out how to differentiate between depression and dementia because a lot of those symptoms are very similar. And then we're going to discuss some of the screening tests that can be useful for detecting late life depression, depression and dementia, cognitive decline in general, as well as delirium. And then lastly, we're going to review treatment options for depression in dementia. So this is kind of the old DSM-4-TR criteria for dementia, and I'm just going to review this for people who have not read this recently. So dementia, according to the DSM, is the development of multiple cognitive deficits manifested by memory impairments, and that's kind of a key point that I'll emphasize, in addition to one or more of the following. So aphasia, or language disturbances, apraxia, so the inability to kind of carry out motor activities despite having the functional ability to use your muscles. Agnosia, so the failure to recognize or identify objects despite intact sensory function. So kind of the old way that neurologists used to assess for this is to give somebody a coin and then seeing if they could recognize what it was with their eyes shut, or if they could recognize what letter they were drawing on their hand. And then executive functioning, which is kind of the ability to plan and organize and just sequence. And these cognitive deficits needed to cause significant impairments in social and occupational functioning and be a big decline from prior level of functioning. And then also very important is that these deficits do not occur exclusively in the course of a delirium. So then we're going to go into major neurocognitive disorder. So this kind of came out in 2013 with the DSM-5. And so I'm just going to review this and then we'll discuss the differences. So evidence of substantial cognitive decline from prior level of performance in one or more cognitive domains based on individual, a reliable informant, or a clinician, and then also a decline in neurocognitive performance. And so this would be kind of most commonly neuropsychological testing. The deficits need to interfere with activities of daily living. Again, they should not occur exclusively in the context of delirium. And they're not attributable to another mental disorder because we know things like depression and schizophrenia have some cognitive issues associated with them. So I think what you'll see, the big difference, is that there's the lack of requirement for memory impairment with the newer diagnosis of major neurocognitive disorder. And I think that's pretty key because a lot of the dementias, particularly the frontal dementias, don't actually present with memory loss, even though we typically think of dementia as memory loss. And so it's kind of important to change this to kind of reflect what we're actually seeing. And then minor neurocognitive disorder. So this looks very similar. So again, cognitive decline, one or more cognitive domains with a modest decline in neurocognitive performance. The big change here from major is that the cognitive deficits do not interfere with activities of daily living. So this was kind of what we would have considered mild cognitive impairment, or MCI, which never actually made its way into the DSM before, but was certainly a diagnosis that was used a lot in studies. Again, the cognitive deficits don't occur during delirium and are not attributable to another mental disorder. So what is cognition? I think, a lot of times family members will come into my office and they really just don't have a concept of what cognition really means. And again, they kind of equate memory loss with dementia. And so it's kind of a good thing to review what this means. And I also, a lot of times, will go over this when I'm interpreting neuropsychological testing with them so that they kind of really understand how that diagnosis is made. So cognition is kind of an umbrella term, and there's a lot of different areas that are involved in kind of intellectual functioning. So there's things like learning and memory, which are kind of the obvious ones, but then there's also language impairment, executive functioning, attention and concentration, motor functioning, and then social cognition. So this is straight out of the DSM-5, and this is really helpful because if you look at it, they not only describe kind of the cognitive domains and what they kind of involve, but also what to look for if people are having problems with specific domains. So things like learning and memory, people might repeat themselves or have difficulty recalling recent events. Language skills. You see a lot of problems with word finding difficulty, kind of talking around words because they can't come up with the right word, or using more general pronouns versus specific names. Executive functioning, especially early in the course of the disease, this kind of crops up a lot, and people might notice just more fatigue when they're involving, doing tasks that involve organization, or planning, and multitasking. And then complex attention, so this is kind of the ability to maintain attention, to kind of pay attention to two things at once. People might have more problems getting distracted by their environment, being able to perform mental calculations. And then perceptual motor functioning, so this is kind of a combination of what we consider praxis, but then also some visual constructual problems. So this is where people have a hard time with kind of familiar activities. So they might have problems kind of orienting themselves in space. They can't put on their pants correctly. Or they might have problems kind of creating a map of where they are in the world, and so you find that they're getting lost in familiar routes when they're driving. And this also can cause kind of confusion with dusk and low light. And so this is kind of what you see with sundowning, where people will kind of misperceive things when it starts to get a little darker at night, and sometimes that can lead to other problems. And then social cognition. So this is kind of what probably caregivers and family members notice a lot and are most problematic for them. And this is kind of the recognition of emotion. So people start to have personality changes. They're less able to kind of read social cues. And they might just be less empathetic or more disinhibited. So you find that they basically lose their filter. And so they're less able to kind of edit what they say, and everything kind of comes out. So now that we've kind of covered the kind of review of cognitive problems, I wanted to kind of go into more general depressive symptoms. So this is out of the DSM-5, and this is the criteria for major depressive disorder. And so what they require is 5 or more of the following symptoms during a 2-week period of time, and it represents a change from prior functioning. At least one of these symptoms needs to be depressed mood or a loss of interest or pleasure. And it's important to recognize that these symptoms really need to be kind of throughout that 2-week period, not just for a one night where they have problems with sleep, or a couple hours of low mood. It needs to kind of persist throughout the entire 2 weeks and really cause a lot of problems. So, and you'll see again, weight changes, insomnia or hypersomnia, a lot of psychomotor agitation or retardation, meaning they kind of are more likely to pace or really kind of slow down, or they might feel like their thoughts are slow or racing, loss of energy, really feelings of worthlessness and guilt, difficulty concentrating, and then recurrent thoughts of death, either passive thoughts of wishing they were dead or actual suicidal thoughts. These symptoms really need to be causing significant distress to meet criteria for a major depressive disorder, and they're not due to another medical condition. Again, that's key because you sometimes will see depressive symptoms in the context of a delirium, and the treatment is very different, and so it's important to kind of make sure that there's nothing else medical going on that might explain it. It also can't be explained by a psychotic disorder, and people can't have a history of manic or hypomanic episodes. So now I'm going to talk more about late life depression and how this really differs from major depressive disorder. And so what you see is that people with late life, a large proportion of them do not actually endorse feeling sad or depressed. What they're more likely to endorse is boredom. And so the lack of interest or the decreased interest is key. You also see a lot more problems with physical symptoms. So people tend to really get kind of focused on somatic things. So more constipation, more physical pain. And then you'll also see a lot more memory difficulties, and we'll go into that a little bit more in the next slide. And then you'll see a lot of psychomotor slowing or agitation. So again, they're either pacing or they're just feeling really slowed down. You might see that they're more irritable, they have more sleep disruptions, and then they might also develop psychosis. So major depressive disorder with psychotic features is not very uncommon in the older population. And so with psychosis, you can get a few symptoms. So you can see hallucinations, so auditory hallucinations, and we typically describe these as mood congruent when they're occurring in the context of a major depressive episode. And so what people will describe is either auditory hallucinations telling them really negative things, so might hear voices that are saying, that they're worthless, that they should kill themselves. So they could even be commanding in nature if they're telling people to do things. The other thing would be that people can develop delusions. So the definition of a delusion would be a fixed false belief. So no matter how much you argue against the person, they're really going to be fixed that this is the actual event that's happening. This is actually occurring to them. And so some of the delusions that people will develop in the context of depression is they might kind of have pathologic guilt. So they might really feel like they're responsible for being depressed or responsible for things that are not their fault. They also might develop delusions of that they have really bad healthcare conditions. So they might believe that they have cancer despite medical workup being negative, or that they're dying. And then the other one is kind of, that's a common delusion, is that they are going to be destitute, that all their finances are gone, that maybe the hospital stay is they're not going to be able to pay for it. And so these are common kind of delusions that can go along with major depressive disorder. So late life depression has just a lot of cognitive symptoms associated with it. So up to 30 to 40% of non-demented older adults with depression actually have frontal lobe involvement. And so you'll see problems with attention, concentration, disorganization. They might have problems with organizing kind of these executive functioning tasks, and then perseveration. And so anyone that's kind of seen somebody with late life depression really can probably hone in on that particular symptom. So you try to distract them from something, but they just keep coming back and ruminating about a particular worry. Typically, these people will have more problems with recall versus recognition. So if I were to see somebody with Alzheimer's disease and I ask them something, they may not remember, what it is I'm asking them to remember. And if I give them a hint, they probably still won't remember anything. But with late life depression, they may not recall it spontaneously, but if I give them a cue, it a lot of times will jog their memory and it will come back to them. The other thing that you'll notice with late life depression cognitive symptoms is that they have less problems with narrative memory. And so this is kind of, they're less able to kind of recall a list of going to the grocery store of what they needed to, pick up at the grocery store, but they will probably be more likely to remember things in the context of a story. And then we can go on into depression with reversible dementia. And so this is formerly known as pseudodementia. So this is where people in the context of a depression develop cognitive impairment that is so severe that it actually looks like dementia, but it does go away with treatment. And so compared to people with actual dementia and then ongoing depression in dementia, these people are more likely to have somatic anxiety, so very fixated on, again, physical symptoms. They're more likely to have early morning awakenings and a loss of libido. But unfortunately, even though you treat this and it goes away and they look essentially back to their baseline, they may go on to develop irreversible dementia within the next 2 to 3 years. So that's just a really high risk group. So what are some of the outcomes of late life depression in general without dementia? So we see that a lot of these people have cognitive dysfunction, and the people, unfortunately, with that cognitive dysfunction, so the 30 to 40%, are going to be more likely to have a poor response to antidepressants and more lethal suicide attempts. If they have mild cognitive symptoms, those do not generally progress to dementia. They may persist, or they may improve and go away with treatment of the depression. Again, though, with the severe cognitive symptoms with depression that are actually looking like a dementia, even if that goes away with treatment, they're going to be more likely to have an increased risk of dementia down the road. So in kind of preparing this talk, it's a very complex subject because there's just such interwovenness between dementia and depression. And so researchers have really looked at this and tried to tease out how these two disorders are related. And there's actually a lot of different ways that they could be related or not related at all. So one example would be if somebody had kind of a history of early life depression. They develop recurrent depression in their 20s, 30s. They have maybe an episode of depression every 5 to 10 years. Then maybe in their late 70s or 80s, they develop dementia, and then they just happen to have another reoccurrence of depressive symptoms. Or a lot of people feel like that late life depression might be a prodromal symptom. So this kind of the first symptoms of dementia. It could be that there's a common risk factor, so people with vascular disease risk factors. The same thing that causes the dementia could also cause the late life depression, depending on where the vascular insult happens. And there's a lot of people who feel like people who don't have depression earlier in life, and their first episode of depression is in late life, or ones that maybe do have more of this vascular dementia. Then there's an idea that, people particularly early in the course of their diagnosis develop this dementia and they have functional loss, and they're aware of this, and then so they might have kind of a reactionary depression. And then there's some other research that's come out that maybe even depression in early and midlife might be a risk factor for developing dementia down the road. So what is the prevalence of depression in people with known cognitive disorders? So it kind of depends on how you define depression. So in general, just general depressive symptoms, not necessarily those meeting criteria for major depressive disorder, it's actually fairly common. So 40 to 50% of patients with Alzheimer's disease have some depressive symptoms. But if you actually are more stringent and use the major depressive disorder criteria, you're looking at only about 10 to 20% of patients with Alzheimer's disease having this co-occurring disorder. And then depressive symptoms can also occur in a large proportion of people with milder cognitive symptoms. So a mild cognitive impairment, anywhere from 3 to 63% of people will have depressive symptoms. And I think that the kind of why this is such a huge range is that this is based on kind of where the sample was taken, hospital versus community, and then how they defined mild cognitive disorder, because again, this was not, or mild cognitive impairment, because this was not in the DSM-4, and also the definition of depression they used. Did they use MDD, or did they use just general depressive symptoms? So now we're going to kind of discuss how to distinguish depression from dementia. And this can be kind of tricky because a lot of these symptoms do overlap. And so with one of the big ways to be able to distinguish depression from dementia is the time course. So people with depression will have more difficulties in a subacute period, so over weeks to months, as opposed to people with dementia having more problems over months to years. People with dementia can have lower moods, but the lower mood is typically transient, and so it's lasting for maybe an hour or two a day, a few days a week. It could even occur daily, but again, it does not last throughout the day. As opposed to depression, you're going to have a persistent low mood kind of throughout the day, every day. With depression, people a lot of times kind of really are aware of their cognitive deficits. They might even amplify it. We always say that if you're really worried that you have dementia, you probably don't. You're probably having more depression. As opposed to people with dementia, they really don't have as many concerns about their cognitive deficits. A lot of times it's the family members that are noticing these problems first. With dementia, you're going to notice more of a gradual loss of interest, and you're going to see some apathy, particularly early in the course of the disease, where they just don't seem like they care. They're just not as motivated to do things. With depression, you get this, but again, it's more subacute, and it may be more extreme. You're also going to see appetite and sleep changes with dementia, just because we know there's sleep architecture changes with dementia. But again, this is going to come over the course of years as opposed to weeks with depression. With dementia, people might notice that they're not able to do what they used to do, and so they will express occasional worthlessness. But in depression, this is much more common, and so this is something that they may fixate on a lot more. And then with dementia, it's pretty infrequent that they have suicidal thoughts, whereas depression, this is more common. So in late life depression, what's the risk of suicide? Pretty much everybody knows that this is high. We know that older adults make up 12% of the U.S. population, but yet they account for 18% of all suicides. And there's some reports that say that suicide may be underreported by as much as 40%. And this is kind of based on this concept of silent suicides. So people who have deaths via overdoses that maybe people thought were unintentional, but they were intentional. Self-starvation, dehydration, or other accidents that people just didn't put it together that this was actually a suicide. The attempt rate is much higher in the younger population, but the completion rate is much higher in older adults. And you'll see this in the completion attempt ratio is actually 60-fold higher in older women versus younger women. And the rate of suicide is 5 times higher in elderly white males versus the general population. So we know this is just a very high-risk population. And then suicide risk in dementia in particular. So this actually hasn't been looked at a ton, but there have been some studies, and the studies are really mixed. And what it comes down to is that this may depend on where a person is at in the course of their illness. So there was a Danish study that looked at this and saw that there was a relative risk for suicide in patients aged 50 to 69, that it was 8 times greater than that same age group without dementia. But then when they got up to 70, it was still high. It was 3 times higher, but it went down with age. And that the period after diagnosis was the time of greatest risk. As a clinician, I look at this and I see that age 50 to 69 is a pretty young onset for dementia. And a lot of times the dementias that you see in that age range are ones with more frontal involvement. So you're going to see more of, again, that disinhibition. And so that may result in more of these suicides. There was actually a study in the U.S., though, actually 2 studies that found no association between dementia and suicide, and one study even showed a decreased risk with dementia. And then there was an Australian study that showed no increased risk in completed suicide, but an elevated risk of attempts. And so again, suicide risk may reduce with progression of the disease, and this may be due to a couple of reasons. It may be that these people now are requiring more supervision, and so they're just less able to carry out an attempt. But a lot of times that's also because these people now have progressed to the point where their cognitive capacity is such that they're not able to plan a lethal suicide attempt. And there's no current suicide ratings that have been validated in this population. And so things like the Columbia scale that looks at suicide just really hasn't been studied much in this population. So I've got 3 cases, and these are kind of based on my clinical caseload that I thought would be kind of useful to help emphasize some of these points. So Mr. H is a 78-year-old male who presented for evaluation of depression, and his family really noticed that he just became really anxious and tearful when they traveled to Texas recently. And he'd just, in looking back at some of the symptoms, he'd withdrawn from a lot of activities he used to enjoy. He was sleeping a lot during the day. It was just hard to motivate him to do much. Appetite was a little lower, but there was really no significant weight loss and no thoughts of death or suicide. His medical history was significant for hemochromatosis, high blood pressure, and then he had a small stroke about 4 years earlier. And when I did some cognitive screening, and we'll go into these tests a little bit more later, his mini mental status exam was 15 out of 30, so probably more in the moderate range of cognitive impairment. And then primary care had actually already seen him before they referred him to me, and they did start him on a low dose of an antidepressant, sertraline, and then also a benzodiazepine, lorazepam, for his anxiety. So since he'd already been started on the sertraline, I did titrate that up to a more moderate dose, and I tapered off his lorazepam, as we know that can cause cognitive problems and gait problems. And then just given his history of hemochromatosis and also this history of stroke, I did refer him to neurology just to make sure there wasn't anything else going on that might be potentially treatable. With treatment, his family noticed that he was less anxious, and they were able to do some small trips around the state, and he was better able to tolerate this changes in environment. He was also more conversational, but he continued to have problems recalling recent conversations and events. And neurology confirmed this diagnosis of dementia and started him on treatment with dual cognitive enhancers, both Aricept and Namenda. So my take-home point from this is, again, he had a lot of symptoms that kind of looked like both depression and dementia. He did have some positive response, but his cognition was pretty impaired, and so it looked, even from the get-go, like it was probably more dementia. It may have been a prodromal symptoms of dementia, and it was good that he got some improvement with the medications. We don't always see that, but in general, he had more of the symptoms that we would associate with dementia. And I didn't kind of emphasize this in the case, but this was kind of more of a gradual, insidious onset. I'm just going to briefly touch on this because you can't have a talk about depression and dementia without at least touching on delirium, because they're so interlinked. And you can have all three. And so again, time course is key in differentiating between all three. So delirium, onset hours, days; depression, weeks to months; dementia, months to years. With delirium, you're going to see more problems where people get confused that it's depression, not delirium, with the hypoactive delirium. And so this is actually what we get consulted a lot on in the hospital. People are pretty well able to distinguish delirium when the person is hyperactive, when they're pulling out their IV lines, when they're hallucinating. People catch that. It's the people who are laying in bed, who are hard to motivate to go to physical therapy, they're sleeping a lot, that people think, well, they're depressed. But then you actually check their orientation and they're delirious. And what you'll also see with delirium is that people can really look depressed. They might endorse a lot of depressive symptoms, but this does go away with treatment of the underlying medical condition. And you might even see that some of the depressive symptoms fluctuate, just like there's fluctuations in alertness, as opposed to depression where the low mood persists. And then again, we talked about dementia where the low mood might be more intermittent. With delirium, you're going to see fluctuations in alertness, attention, cognition. With depression, we talked about the cognitive symptoms that you will also often see with that are more executive functioning problems. And then with dementia, I just wanted to kind of emphasize the fact that this is just a risk factor for both. So people with dementia are at high risk to develop delirium. They also obviously have a high rate of having depressive symptoms with their cognitive problems. So what are some of the screening tools that can be used to help distinguish between these conditions, and also to kind of assess the severity of these conditions, because we know that these conditions are interlinked and it can be really hard to tease this out. So with delirium, we often use the CAM-ICU, and I'll kind of go into each of these more and more detail in the next few slides. With dementia or cognitive decline, a lot of times we'll use the Mini Mental State Exam or the Montreal Cognitive Assessment, so the MoCA and the MMSE. With depression, late life depression, a lot of times we'll use the Geriatric Depression Scale. The PHQ-9 is a lot of times used in primary care. It sometimes is used in the elderly population as well. And then with people with known dementia, to assess for a new depression, the Cornell scale for depression and dementia can be very useful. So this is the CAM-ICU, the Confusion Assessment Method. And initially this was developed, there was kind of a verbal component to this test. So then they developed the ICU method to really help out with patients who are not able to verbally communicate. So in the ICU setting, people who are intubated, they really wanted to be able to pick up on delirium. And what you see is there's kind of a nice flow chart of what you need to go to diagnose delirium, or at least assess for it. So what you're going to key is to really recognize if there's been an acute change or if there's been a fluctuation in their mental status. So even if you're coming on your shift and the person's looking great, if you got a report the night before that the person was agitated or having problems with confusion, that would be a fluctuating course and a change, and you would want to go on and continue with the assessment. If there really hasn't been much of a change, then it's probably less likely to be delirium. So if there's been a change, then you go and check for inattention. And there's either a picture form of this test, which I actually don't have with me today, or there's kind of this more of a verbal form. And again, people can they don't have to verbally communicate. They can just use motions. Like in this test, it's squeezing your fingers whenever you say a specific letter. So you say, squeeze my fingers whenever I say the letter A, and then you read a sequence of letters and just see if they can continue to keep up with that. So it's kind of measuring perseverance. And what you'll often see when people are delirious is that they start out with, the first one's correct, and then they just start squeezing for every single letter. Or they kind of might completely lose focus and just stop squeezing altogether. So if they have 0 or less than 2 errors, they're less likely to have delirium. If there's more than 2 errors, you need to keep going on in the test. And then you looked at levels of consciousness, and this is using this Richmond Agitation Scale, or the RASS scale, which is in the next slide. And if that's 0, or if it's anything other than 0, then it's probably likely that they have delirium. If it's 0, you still need to go on and look at disorganized thinking. So kind of looking at logic questions. Will a stone float on water? Are there fish in the sea? You can also use kind of fingers. So hold up 2 fingers. You don't do that, but you have them and see if they can do it. And then see if they can add 1 more finger and see if they can kind of do that mental calculation in their head. So if all of those are negative, they're less likely to be delirious. Here's the Richmond Agitation Sedation Scale, and you'll see that 0 is normal, alert and calm. As you go from 1 to 4, you're looking at more hyperactive delirium. As you're looking negative numbers, -1 to -5, you're looking at more hypoactive delirium. So again, the KMICU was used to aid in the detection of delirium by non-psychiatrists. A lot of times this is administered by nurses, particularly the ICU nurses. And this is used to help with patients who are unable to verbally communicate. So I wanted to kind of look and make sure that this had actually been studied in the population with dementia, just because we know that dementia, again, is a risk factor for developing delirium. And there has been a study on this. And the way we kind of look at how good a test is at picking up on things is we look at sensitivity and specificity. So I'm not a big biostats person, but just to kind of review this for you, sensitivity is kind of looking at a test being positive when there is a specific disease present. Specificity would be a test being negative without a disease. So for screening tests, we really want something that's sensitive. We want to be able to pick up on things. Even if there's a false positive, we'll go on and do a confirmatory test later. So we really want high specificity or high sensitivity. So in people with suspected dementia, this test was actually pretty darn sensitive and specific. So 100 is pretty much as good as you can get, and they were near 100 for both of them. For adults greater than 65 years of age without dementia, it was still pretty sensitive, but it was a little less specific, so they were more likely to have some false positives. So now going into kind of more measures of cognitive functioning in general, the mini mental state exam has been out for years, pretty much developed in the 70s by Dr. Folstein out of Johns Hopkins, and it's one that people are most familiar with, so I'm just going to go on here. It's the most studied test, and it's really good for communicating kind of where somebody's at cognitively to other clinicians. So most people, this has been around so long that they kind of have an idea of what somebody with a score of 22 out of 30 would look like as opposed to somebody who's scoring a 15 out of 30. And because it's been around so long, it's been the most studied, and so there's a lot of information on sensitivity and specificity. What you'll see is that this test is pretty good at looking at dementia. So using a cutoff of 24, it's got a sensitivity of about 88%, a specificity of about 86%. What you see that this test kind of is not so good at is at picking up on milder cognitive problems. So mild cognitive impairment, the sensitivity is about 45 to 60%, even using a higher cutoff, and specificity is in the 60s, is a pretty variable, 65 to 90%. What you'll also see is that there's kind of a ceiling effect with either higher intellectual background, so higher IQ, or higher background educational levels. So those people with higher cognitive reserves, it takes more loss for them to show up on this test. This test was great when it was developed because it was free and everybody was using it. And then sometime around, I'm trying to think, it was around 2006, it got copyrighted. And so now there's technically a fee associated with this test. The other thing I like about this test also is that it's really good for estimating average annual cognitive change. So it's been pretty well studied in this, and so you can kind of say somebody with Alzheimer's disease, if they're just kind of progressing along the normal rate, they're going to lose about 2 to 4 points on this test in a given year. And this can be really useful. I like to get baselines of the mini mental on most of my patients, because say they end up in the hospital 6 months later and people are, noticing that they have cognitive problems. And even if they had some cognitive problems at baseline, say they had a mini mental score of 21, they go into the hospital and now you test them and they're at a 10. And so you say, well, you know what, this is an 11-point drop in 6 months. This is more than I would expect for dementia. Don't attribute this to just dementia or progression of dementia. There's probably another underlying medical cause that's causing this. They've got a delirium and you need to be checking this out. And then the Montreal Cognitive Assessment Test. This has really kind of become big in the last probably 10 years. And what you'll see some key differences with this test is that it picks up on more of kind of those executive functioning tasks that the mini mental sometimes doesn't. And I think because those are a lot of times what you see earlier in the cognitive process or the dementia process, this can make this test a little bit more sensitive in picking up on earlier cognitive decline. And so you'll see kind of the trails B, where you're alternating letter and number. That's kind of a test of executive functioning. And also verbal fluency, where you kind of come up with as many words as you can that start with the letter F in 1 minute. That can be a test of kind of executive functioning. And so this, again, is more sensitive at picking up on mild cognitive impairment, using a cutoff of 25 to 26. Pretty sensitive at dementia, a little less specific than the mini mental state exam, so you're more likely to pick up on maybe some of the problems with depression, because a lot of those people have executive dysfunction as well. There's less of a ceiling effect, so I use this on people who have kind of a college background or a little bit higher education, because you're going to be more likely to pick up on kind of the earlier cognitive loss. It is free, or at least it was. I recently logged on, and now they're wanting you to register and maybe pay to be trained, but it's out there, and it's not necessarily copyrighted. It's been validated in a lot of pathologies. Some of the limitations, it really hasn't been kind of validated or verified in kind of more diverse settings or in people with lower educational levels. And then it's been studied less in what the average rate of decline with dementia is. And so there's one study that said maybe 1 point change per year, a Parkinson's study that showed really no change in 3 years. What I would say is because this is better at checking executive functioning, and that often comes on earlier in the course of the disease, you'll actually probably see more of a drop in this earlier, and then it tends to plateau. So now looking at screening tests for depression, the Geriatric Depression Scale is a commonly used scale. This was initially kind of a self-administered test. This version that I have up on the screen is not self-administered, because you obviously see the bold print for what positive responses are. But what you'll see with this was developed to kind of take a shift away from some of the physical symptoms that a lot of the depression screening tests emphasize, because we know that people, older adults, have more physical symptoms in general. And so they really try to focus on more of feelings of worthlessness or more of the emotional aspects of depression. And the original version was 30 items. Probably more familiar with the short version is 15, with a cutoff of 5 and over being concerning for depression. It's nice because it's got about a 4th grade reading level, so it's really, you can use this in a large group of patients. And it's pretty sensitive and decently specific. And then the PHQ-9, this is probably more commonly used in primary care settings. This is kind of 9-item test, and then you rate the severity, so it's up to 27 points. Anywhere from 1 to 4 is minimal, 20 to 27 is more severe. And this has got, anywhere from a reading level from 3 to 8, so pretty much less than 8th grade you're going to be able to understand this test and fill this out accurately. Major depressive disorder is more likely at scores greater than 5. It hasn't been studied quite as much in the elderly population. I did find one study on this using a cutoff of 8, and it was pretty sensitive and specific. The same study showed the Geriatric Depression Scale to be more sensitive and less specific. Again, I would prefer that things be sensitive. I want to be able to pick up on things even if I have a false positive, especially in the case of that the follow-up test is not invasive. So really, if you have a false positive, the only thing that you've lost is maybe an hour time with a psychiatrist. And then the Cornell scale for depression and dementia. So this is for people with known cognitive problems, known dementia, and then you're trying to assess and see if they have a new mood disorder. And so this is actually, there's 19 items. This is kind of a truncated version of it. And you'll see that it's hitting on multiple different areas. What's nice about this is that it uses an outside informant, because obviously people with dementia are less able to remember some of their symptoms. So a score greater than 12 is indicative of depression. And this is pretty good for people with mild to moderate dementia. Actually, I read somewhere that with really a mini mental state of about 15, the geriatric depression scale actually starts to be less valid in that group. But the Cornell scale kind of holds true in that population. Is pretty good at picking up on depression. And it's pretty good sensitivity and specificity using a cutoff of 7. So next case, so Miss She is an 89-year-old, recently widowed female who's hospitalized for pneumonia. She was sent to a skilled nursing facility to undergo rehabilitation. And while at the facility, she was noted to be tearful and confused, and psychiatry was consulted to assess for depression. So her history was significant for high blood pressure, high cholesterol, and a history of knee replacement. Her social history was really significant for her husband having passed away 4 months earlier, and she had no history of significant substance use. So in this case, it was really key that we got collateral information from the family. And her daughter was able to provide a lot of useful information on the time course that allowed us to kind of distinguish what was going on. So her daughter said, she's had a 2 to 3 year history of gradual memory loss, but she was able to live independently with her husband. Unfortunately, when he passed away, the daughter noticed just a significant worsening in her mood and memory. And she just started making comments about feeling worthless and wishing she was dead. And so much that the daughter actually had been living with her to kind of help her out. But then she developed this pneumonia, and her daughter noticed just a significant increase in her level of confusion. So this was huge, that the collateral really gave us the time course to distinguish that she actually had all 3 Ds. So she had, kind of this insidious onset of memory loss that was consistent with dementia. She had these depressive symptoms after her husband's death. One could conceptualize that this was just bereavement. However, bereavement typically doesn't cause these intense feelings of worthlessness or thoughts of death like suicidal thoughts. And then she had this abrupt change in cognition in the context of a medical illness that was consistent with delirium. Now, one of the key things I just kind of want to focus on is, in her case, for outcomes, we did not treat her right away. So some of the antidepressants, can, on rare occasions, can cause delirium of themselves. And so typically when people are in the midst of a delirium, we like to let them clear up, see what we're dealing with, and then initiate treatment if it's still indicated. So now I'm going to kind of go into treatment types, and we're going to kind of discuss pharmacotherapy, psychotherapy, and then kind of exercise or other supportive therapies. So pharmacotherapy. So this was kind of interesting. Now this is what we're going to focus on in the treatment is in people with depression and dementia. And this is going to be a contrast. So we know that people with late life depression without dementia do respond to antidepressants. But what was interesting in reviewing the literature on this is that the pharmacotherapy results for people with depression and dementia are less positive. So there's actually been 2 recent trials that were negative. So people received an antidepressant, they received a placebo, both people improved, and there really wasn't any difference in the drug treatment group versus the placebo group. So the DIAD-2 trial came out in 2010, and this was looking at sertraline in the treatment of depression and Alzheimer's disease, and they actually used pretty good doses. So mean dose of 91 milligrams, kind of a wide range of cognitive dysfunction with a mini mental state of 10 to 26. And again, negative, so both people improved, placebo and antidepressant. And then the HTA-SAD study looked at sertraline, mirtazapine, and placebo in depression and dementia. Again, using pretty decent doses of these antidepressants, kind of an average range of cognitive dysfunction, and again, it was negative. There's also been 3 meta-analyses looking at this, and 2 out of 3 of them are negative. And the people, that have been taking the antidepressants did have side effects. So they had a lot of the SSRI, typical SSRI side effects of diarrhea, indigestion, dry mouth, dizziness. So it's not completely benign medications. What it came down to is that these people might not be responding to these medications because the depression symptoms that they used in these studies just were not as severe. So they used kind of any depressive symptoms. They didn't cut it off at major depressive disorder. And what we see is even in younger population of depressed people that there's a high placebo response. These people, it's really hard to see a treatment effect with medications, and the same may hold true for depression and dementia. So who may benefit from an antidepressant when they have depression and dementia? So maybe the people who have a history of recurrent depression prior to the dementia onset, people who've had a positive antidepressant response already, or people who have more severe depressive symptoms. Now I'm going to kind of throw a wrench in this because antidepressants now are being used for behavioral and psychological symptoms of dementia. So there's been a couple of studies really that have been reviewed this. So the CIT-AD, or the citalopram and Alzheimer's disease study, came out in JAMA in 2014, and they noticed improvement in a lot of kind of more of the behaviors. So these would be more like agitation. And with the CIT-AD study, they actually even noticed some improvement in psychosis. And so some of these antidepressants are being used for behaviors other than depression. There was even a Cochrane review in 2011 that looked at citalopram and sertraline and showed a reduction in agitation versus placebo. And then there's also been one study that came out in 2012 in the British Medical Journal that looked at how do people respond to withdrawing antidepressants when they were used, when the antidepressant was used to treat behavioral and psychological symptoms of dementia. And what they noticed was that there was an increase in depressive symptoms. So I guess my take on this is to look at the whole person. If they've got mild depressive symptoms, not a lot of behaviors, not a lot of agitation, it may not be worth the risk to start an antidepressant. If they've got more severe depressive symptoms, or if they've got mild to moderate symptoms in addition to a lot of behaviors, then it might be worth a trial of an antidepressant. The important thing to recognize is that if you're going to start an antidepressant, that you need to really start low and go slow, kind of the old standard that we say with all of geriatric medicine. But with people with anxiety, and there's so much somatic anxiety associated with depression, I really start at like a quarter of the starting dose of antidepressant, because we know that SSRIs can be a little activating, so this kind of helps offset some of the activation, makes it better tolerated. It may take a little longer to get them up to a decent dose of the medication, but you'll be able to keep them on the medication long enough for it to work. The other thing is that older patients are much more prone to develop hyponatremia with SSRIs, and so it's important to maybe check a serum sodium within the first 7 to 10 days just to make sure their sodium's not dropping, particularly people who have a history of hyponatremia. They're going to be much more at risk. And then be mindful of drug interactions. This is kind of an obvious point, but something kind of to think about is that these people are on a lot of medications. You may pick an antidepressant that does not increase an INR if they're on Coumadin, but it's important to recognize that antidepressants have their own bleeding risks. So there's an increased risk of GI bleeding just because antidepressants, particularly SSRIs, affect serotonin, and there's serotonin in platelets, and that affects platelet aggregation, so they're not able to clot off. So if somebody's on Plavix or aspirin and you add an antidepressant, you just need to be aware that there might be a little bit of a higher risk of a GI bleed, and you need to be monitoring their stools for any black and tarry stools or blood in their stools. Psychotherapy. So I thought this was kind of interesting when I was reviewing this information for this talk, because typically we don't think of psychotherapy as being that effective in dementia. In fact, there's some concerns about Medicare fraud. How can you do therapy in somebody who doesn't have the cognitive abilities to hold on to that information? But there's actually a lot of information on specific therapies that are effective for depression in dementia. So this kind of goes from more earlier dementing processes to more severe. So things like problem-solving therapy can be very effective in people with mild or cognitive problems. So in this type of therapy, people are encouraged to identify problems, kind of brainstorm possible solutions, kind of create an action plan, and put it into effect, and then see how effective it was, what got in the way. And what they've seen is that this type of therapy is really useful for improving interpersonal relationships, communication deficits, and also just increasing behavioral activation in general. Then there's a type of therapy called ecosystem focused therapy. It's kind of an unusual name, but that's pretty much what it is you're modifying the patient's ecosystem. So that, what is their ecosystem? It's their environment and it's their caregivers. So you're looking at making it more amenable to their symptoms and kind of maybe changing how caregivers approach patients to improve their mood. There's problem adaptation therapy, or PATH, which is using kind of a combination of the problem-solving therapy and the ecosystem-focused therapy to kind of target both to improve their mood. And then there's behavioral therapy, and this is kind of more for people with moderate to severe dementia. And so this is kind of working on positive activities, and again, working on caregiver trainings to really try to improve their approach and see if that can have positive outcomes in the patient's depressive symptoms. Exercise. Now this I thought was really interesting in reviewing some of these recent studies. I think in general we think exercise is good. It's helpful for the mood. There's endorphins. But actually a lot of the studies for looking at depression in dementia have been negative. So there was a Cochrane review that was just updated in 2015. They reviewed 5 trials. Really no evidence that exercise improves depressive symptoms in dementia. There was some possible improvement in the ability to perform ADLs, and in general I would say exercise is good, but they're just not seeing the improvements in mood with exercise alone. And there was also a meta-analysis in the Journal of Aging in 2015 that really, it showed a trend towards decreased depressive symptoms, but it was not statistically significant. And so caregiver interventions. So what are some things that caregivers can do to kind of help with some of these depressive symptoms? So this would be kind of really general things, but it may be that these caregivers haven't thought of this, is listening without judgment and trying not to just correct people right away. If they start kind of perseverating on feeling worthless, don't disagree with them, let them talk and say, I'm sorry you're feeling that way. But what I see is that you still contribute a lot, and just try to kind of, you can express your viewpoint, but not in a corrective or punitive way. Be really empathetic, and then really focus on behavioral activation. I like to think this behavioral activation to me comes down to kind of the notion of fake it until you make it. So there's a lot of evidence that if you can force people to kind of get into their normal activities, their normal daily structure, even if it's really hard and even if they don't want to, that their mood will actually improve down the road. And so a lot of times these people just really need structure to their day. They need to have positive activities scheduled for them, and that'll kind of build on itself. We want to increase social activities, but people need to be mindful that they're not overstimulating. For people with cognitive problems, they can be easily overstimulated. So yeah, you want them to be involved in social settings and family outings, but you might want to avoid the 3-year-old's birthday party. So last case, just to kind of end on a positive note, this is Mrs. C. She's a 76-year-old female who had the onset of multiple physical symptoms 6 months ago. She had been seen by numerous specialists with no physical causes found. She had also developed a lot of anxiety and difficulty managing household affairs. So psychiatry was consulted during an admission for abdominal pain where they couldn't find any physical cause. Her medical history was significant for high blood pressure, high cholesterol, reflux, but she had no past history of depression or anxiety, and she just had a great family, very supportive husband and children. So when we evaluated her, she just had all the symptoms of a major depressive disorder. She had sleep disruption, lower energy, lower appetite, with a pretty good weight loss over 6 months, 25 pounds. Passive thoughts of death, was so much psychomotor agitation. She just could not sit down in the examination room, just pacing around. And we really tried so hard to get her to take an antidepressant, but just were not successful. She'd either forget to take it, or she'd just be so anxious that she would refuse to take it. So ultimately, we ended up hospitalizing her on our geriatric psychiatry unit. And, with strong support of her family, we actually administered ECT, so electroconvulsive therapy. And after 6 treatments, she really showed a significant improvement in her mood, her physical complaints, and her cognitive symptoms. So despite the fact that ECT can cause cognitive problems, she actually had improvement. And she's been able to be maintained on an antidepressant and is still doing fairly well. So kind of a positive thing on somebody who who really just was adversely affected by late life depression. And you could see the time course where this came on over a 6-month period of time, more indicative of depression than, 2 to 3 year history, which would be more indicative of dementia. So these are some things that I hope you were able to take away from this talk. Kind of key things that I thought were important is that there are other areas of cognition that can be affected by dementia other than memory. That cognitive changes, particularly those affecting executive functioning, often accompany late life depression. The relationship between depression and dementia is complex and variable. Screening tests can be really useful for detecting depression and cognitive impairment secondary to dementia or delirium. Antidepressants, although effective in late life depression, may not be very effective in treating mild depression in dementia. And then different therapies like problem-solving therapies, environmental changes, along with caregiver education, can be effective in treating depression in dementia. I want to thank you very much for taking the time to watch this talk.